There are many national and international organizations that evaluate evidence-based trauma treatments and update their guidelines. And two important ones are the NICE and the ISTSS. Both recommend individual trauma-focused CBT, prolonged exposure and cognitive therapy for PTSD as a first-line treatment. However, for EMDR therapy, there are remarkable differences in their recommendations. ISTSS strongly recommend EMDR and NICE has a conditional recommendation. That is, only to use EMDR therapy as an option if youngsters do not engage with or do not respond to trauma-focused CBT. And the question is, of course, well, how can we explain this difference? And a contributing factor might be that those guidelines have different inclusion criteria for studies, with as a consequence that the NICE guidelines have only included 4 of the 8 available RCTs of that time. It makes very clear that EMDR researchers need to enhance the number of methodologically rigorous studies, so with larger samples, with long-term follow-up, and that we need to take care that all data are available for the guideline committees. So far, 11 RCTs have been published, with participants mainly covering an age range of 8 to 18 years, who have been exposed to a range of traumatic events, including sexual and physical abuse, medical trauma and single event trauma like natural disaster, accidents and assaults. And in those studies, individual EMDR therapy is compared to waitlist, to standard care and psychoeducation. And 5 of them are comparison studies comparing EMDR versus a form of trauma-focused CBT. The EMDR is resulting in significant loss of PTSD diagnosis and is effective in reducing PTSD and comorbid symptoms like depression, anxiety, behavioral problems, and all compared to the control condition. These effects are achieved within a small number of sessions, 3 to 9, and the effects are maintained in the short and the long term, with the longest term measured is 1 year after treatment. The comparison studies between EMDR and TFCBT show that both methods are equally effective and that EMDR is more efficient, meaning that the same results are achieved in less therapist contact time and in fewer sessions, which is an interesting finding in times where cost effectiveness is an important topic. One of the studies used a stopwatch to measure the exact time used in EMDR therapy, and that's how we found out that it took only 2 hours and 20 minutes to reach reduction in all symptoms, and compared to the TFCBT condition, that was writing therapy, where it took 3 hours and 47 minutes to reach reduction in all symptoms. And that's a really good result. Even 100% of the children in the EMDR group were PTSD free even 1 year after treatment. So it's an amazing result, realizing that children with PTSD can fully recover from their PTSD within a brief time frame. For the rest, there was low dropout, there were no adverse events. So EMDR for children is effective, is efficient and can be safely applied. There are 4 areas that have priority, and that is effectiveness of EMDR in children aged 0 to 8. With PTSD, it's an unexplored area. That is in youngsters with complex PTSD and in disorders beyond PTSD like depression and chronic pain. And finally, research to cost effectiveness for EMDR therapy in pediatric PTSD is important. I hope and really think that in a few years EMDR is recommended in all national and international guidelines as a first-line treatment, so that it will be available for all children in the world. And I'm confident that EMDR can help improve a range of mental health conditions in youth.